Now coming to the medical management, the current concept, future thoughts, what is the rationality, what the scope, molecule and limitation. Let us have a brief analysis in detail about it for that. Rationality, because in endocrine dependence. Ectopic endometrium versus eutopic endometrium already clarified, and again I'm giving a emphasis on that also. Chance of recurrence is there, surgical skill, risk, efficacy and limitations of surgery could be one of these rationality of medical indication for that. So the changing concept shift from surgical to medical, recurrent endometriosis, deep infiltrative endometriosis, the new concept, atypical sites endometriosis and adenomyosis. There is no option other than medical management for that also. And therefore, we must find out a very suitable medical molecule, the new molecule which covers the pain relief, fertility augmentation and cytoreductive one for that. And this is what the clinician like us want. The cost should be less, the compliance of patients, duration of therapy should be as minimum as possible, side effects absolutely minimal, it could relieve the pain adequately, fertility augmentation to a significant extent, reduction of volume of disease to a considerable extent for that. And then by searching for a new molecule, and then the new molecule has come for the last months. It is not completed years also. For the last 8 months, it is marketed in India, GnRH antagonist, which could be there for that. So what are the evidences for the GnRH antagonist? Few of the evidences. Varsellini et al. An in-depth analysis of medical evidences. It guidelines from ASRM, SUG, and S3 and Canadian Society. Literature search from 2010 to 2020. 4,732 manuscripts on results of medical therapy. 73 articles selected. Emerged the concept of progesterone resistance and finding out alternate options. That is GnRH antagonist for that. So the unmet need, the first line medical therapy, OCPs and progestogens, effective in 2/3 of women in relieving symptoms. Limited long-term efficacy. Second line therapy, GnRH agonist, preferred for non-responders to first line therapy, but associated with bothersome menopausal symptoms like hot flash and vasomotor symptoms and bone mineral density affections for that. And long-term efficacy has become a big question mark for that. Surgery has its own limitations because skill recurrence complications could be there for that. And therefore, the need of the hour, a molecule, a long-term, oral, low cost, with maximizing efficacy in terms of pain relief, as well as fertility augmentation and minimizing side effects. And the GnRH antagonist could possibly solve all these issues for that. And therefore, the endocrinological concept of GnRH antagonist, the Barberry threshold hypothesis was there. Ideal solution lowering E2 level enough to induce amenorrhea and treat symptoms while maintaining sufficient levels to mitigate severe side effects like menopausal symptoms and BND. So partial suppression is the major thing, advantages for this Elagolix. E2 estradiol suppression up to 30 to 60 picogram per ml range is optimal. Compromise between efficacy, tolerance and safety for that. And this oral GnRH antagonist is the ideal new option, are oral short-acting treatments for endometriosis to the pain for that. And that got a rapid suppression of LH and FSH, and gonadotropin suppression leads to dose-dependent decrease, that is in between 30 to 60 picogram for that also. So the ideal new option, competitive blockage of GnRH receptor, dose-dependent suppression of FSH and LH production, inhibit secretion of ovarian steroid hormones for that. So main advantages of GnRH antagonist, immediate gonadotropin suppression but no flare of effect. Dose-dependent estrogen suppression from partial suppression at low doses to almost full suppression at high doses, and rapid reversibility and recovery of hormone secretion after stopping the treatment, possibility of individual dose tailoring to balance efficacy and safety for that. There are expected estradiol levels under GnRH agonist was comparison between GnRH antagonist. So full suppression occurs with GnRH agonist, but partial suppression occurs with GnRH antagonist. But in high doses with GnRH antagonist, full suppression can be there for that also. So out of all the GnRH antagonists, the availability in market is about Elagolix. There are 4 GnRH antagonists which is under research and trial, out of which the Elagolix, Relugolix, Linjagolix and ASP1707 for that. So Elagolix and Relugolix have been improved for endometriosis. Linjagolix and ASP1707 has been evaluated in ongoing clinical trials for that. But Relugolix is not available in India. Marketed is Elagolix for that. And The Elagolix Oral GnRH Antagonist superior benefits. How it does it? It binds competitively to the GnRH receptor in the pituitary gland and blocks endogenous GnRH signaling. Rapid suppression of LH and FSH. Gonadotropin suppression leads to dose-dependent decrease in serum estradiol concentration. Hypoestrogenic state stimulation manages the endometric lesions, resulting in pain relief for them. And see the key milestones. It is 2025, but started 20 years of research. It's not an easy job for that. And in 2004, phase 1 trial started with that, and phase 2 trial started with 2010. 2018 approved by US FDA for use in endometriosis, but 2020 US FDA approved it for uterine fibroids, but 2024 it is approved by DCGI, and then it is being available for use in India, country like India for that. And this is a molecular information. I need not emphasize more. The non-peptide GnRH antagonist, oral administration, rapidly absorbed, and the half-life is 2.4 to 6.3 hours for that. So Barbieri has suggested that estrogen threshold hypothesis, the optimal goal of medical therapy. Again, I must say that estradiol less than 20 picogram per ml usually causes lesions to regress, and a concentration greater than 60 picogram usually supports lesions for growth. So it is between 30 to 60 picogram per ml. A partial suppression could be an ideal compromise for that. And there are EM1 and EM2 studies, the Elaris 1 and Elaris 2 studies there. Elaris 1 studies is that 150 milligram once daily for 24 months, and the Elaris 2 studies that 200 milligram twice daily for 6 months for that. In one, we get a partial suppression. In others, we get a complete suppression for that also. But in country like India, once this is recommended, you gynecologists can find out some of the newer innovations for that. And jugaad is a normal phenomena in Indian sentiments for that. You can have a jugaad and you can modify the dose treatment for that also. Instead of 150, you can give 300. Initially, you can give for 1 month the higher doses, and then gradually tailoring up for that, which is not recommended by these researchers for that also. And that could be solving the solution for that. And therefore, Elagolix 150 milligram and 200 milligram both are available, and recommendation is 150 milligram OD for 24 months, 200 milligram BD for up to 6 months for that. So 150 milligram OD for 24 months is a mild dysmenorrhea. In a severe dysmenorrhea, the higher doses are required. 200 milligram BD for 6 months for that. You can do a compromise and a jugaad, as I told you. 200 milligram BD, you initially start for 1 month. Then you can compromise that, yes, 150 milligram daily, you can go for another 2 months for that. It all depends. I think it's a new molecule. You have tried, just recently trying it. You modify and find out a different modality for Indian patients for them. And this is the recommendation for DCGI about 150 milligram OD for 24 months and 200 milligram BD for 6 months according to these two trials for that EM1 and EM2 trial.